All right, so we're getting close to the end. Tonight's actually gonna be probably the last lecture for like clinical stuff. So, well, I take that back. Saturday morning, Jesse Maybe is doing, your OB lecture, so we know how to catch babies. Don't freak out about it, because regardless if you're there or not, the kid's coming out. So, babies have been born long before there were EMS and doctors, so it's okay. But we do have to cover it, so that'll be probably about an hour kind of lecture, and then Saturday is gonna be kind of practice wound care, splinting, kind of catch-up stuff. The following Wednesday, I think, is just kind of open lab night, so just more hands-on practice of everything we've done up to this point. The following Wednesday is RTAC, Regional Trauma Council's coming in and doing a triage mass casualty incident. And there's one more Wednesday after that, which is just gonna be all hands-on practice. And then Saturday the 25th, where we take a written final and we test out of your skill stations. And that's it. And you are first responders. So what I have here in my hand is your final exam. Not gonna give it to you tonight, but if you want to take out a piece of paper, it's probably the good time that I said we would prepare you. And we'll kind of go through what's to be expected on the exam. The exam does require, you will have to complete one 3-page essay with at least 5 citations. The exam is all multiple choice. So if you like writing essays. Now, I do have to say, and nobody needs to say anything, you can email me, call me privately. But if you do need accommodations for taking these type of tests, please just let me know and we can make those accommodations. Like, not take it?
Take it for me?
Oh.
No.
You know, because there's, you know, one of my best friends who's a paramedic has, you know, dyslexia, really bad. And with the proper accommodations, you know, he passed the paramedic national registry first try. So it's not, to have accommodations for test taking stuff isn't, it's common. We do it more often than that. But without further ado, we'll kind of get started. So it's going to kind of flow through the chapters of the book as you go. Obviously, first question kind of starting with the preparatory type stuff, moving through mass casualty. So we'll cover some things tonight that we haven't actually covered in class yet, but we'll kind of touch on. So, if you need me to slow down or stop, please let me know. And remember that for the final, you can use 8.5 by 11 sheet of paper, front and back, to cram as many notes as you want on, or pictures, or whatever you want. Okay, so there was a paper written in 1966 that you might want to know is kind of responsible for the modern day EMS system. And I kind of got to look at these a little bit too. Know your priorities of an EMT. Now, priorities, I mean, like your safety, your partner's safety, patient safety, kind of what order. Know what type of protective gear we should be wearing on roadways. I will say in this test, it does assume that you're not firefighters, so what would we expect a medical person to be wearing on a roadway? You know, like something that might look like a reflective vest. Know what a communicable disease is. not asking you to break down the difference between bacteria, virus, fungus. Just know what that is. Know the best way to stop the spread of infection. In fact, what's the best thing you can do to prevent disease?
Wash your hands.
Wash your hands. Know what your critical incident stress programs or management is? I would know what a pathogen is. Again, super generic definition, not specific pathogens, just what a pathogen is. Methods for making a scene safe. Know the actions when presented with a do not resuscitate. So does do not resuscitate mean do not treat? Correct, two different things. So if I have a do not resuscitate and I break my arm, can you split my arm? Yes. But if I have a do not resuscitate and my heart stops beating, do you do CPR? Know the 4 points of negligence. Know what HIPAA is and what it pertains to. That's the Health Insurance Portability and Accountability Act. Know the difference between open and closed-ended questions. When lifting and moving people, what should we use? Do we lift with our back? Okay, good. Not unless you want to end up like me. I would know the difference between body positions in regards to prone, supine, and lateral recumbent. Know the differentiation of proximal and distal. I would know the basic names of the bones in your arms and legs. I'm not talking about carpals and tarsals, I'm talking humerus, radius, ulna, femur, tib, fib.
You said of bones in the body or?
Arms and legs. I'm not gonna expect you to, differentiate facial bones and the membrane and things like that. Just your basic structure.
What was it, 4 points of what?
Basic airway structures. Oral pharynx, nasopharynx, trachea, bronchus tubes. And the basic functions of the respiratory system. We talked about this before, but know the sequence of air as it goes from here into your lung, meaning, nasal, oral pharynx, down the trachea, bronchial tubes, like we said, but also know the drop of blood as it moves through the heart. Comes into the right side, goes out to the left side to the body. Know the big problem that can happen with left-sided heart failure. Left-sided heart failure. know your major arteries in your legs and arms. So your legs have the femoral artery, arms have the brachial artery.
Bless you.
Yes, bless you. The generic components of blood, red blood cells, platelets, white blood cells, plasma, kind of basic function, meaning like red blood cells carry oxygen, white blood cells fight infection, platelets help form clots, and plasma is what carries everything. Know what organ utilizes the most sugar or glucose? Be able to differentiate your spinal column and how we name it from top to bottom, meaning, and what I'm talking about there is like, you know, the difference between cervical, thoracic, lumbar, sacrum, and coccyx.
We have to remember how many are in each.
No. I would do that. 7, 12, 5, and 2. Be able to differentiate what, you know, what is stridor, what is wheezing, what gurgling could indicate, snoring. So the different airway sounds, you know, kind of what might be upper airway, lower airway. What do you do if you can't find a radial pulse on somebody? Where's the next place we check? So if I can feel a pulse here. Yep. Go to the neck. Corral. Know what normal capillary refill would be in pediatrics? Capillary refill, so if I got a 2-year-old, push down on the nail bed, I should have cap refill in less than 2 seconds. Know what blood vessel we should be listening to when we listen to take a blood pressure, what the name of that blood vessel is.
I'm sorry, what was that last one?
When we're listening for a blood pressure, we're putting a stethoscope over a certain blood vessel. It's an artery, so that's what we're listening to. Know which artery that is. Know the difference between systolic and diastolic blood pressure. So what does the top number indicate and what does the bottom number indicate? Is this an okay speed?
It's
Know the acronym SAMPLE and OPQRST. And for example, what does the M in SAMPLE stand for?
Medications.
Your appropriate order of assessments. So there's like scene size up, primary assessment, secondary assessment, like in what order we do those. know how to manage if a patient is snoring, respirations, if they're gurgling, so like snoring, we position the airway, they're gurgling, we suction the airway. No normal skin finding from concerning skin findings, and meaning, someone, normal skin color, and in the textbook, you say pink and warm, yeah, or, well, what doesn't take into account, and it doesn't test you here, is for dark skin, be it African American, it's much harder, we gotta look more at, the gums, some mucous membranes, but the test here just, we know pink, warm is normal, pale, cool, moist is abnormal. Know what medications are commonly administered via a metered dose inhaler? Does anyone know what an MDI is? It's a fancy word for an inhaler.
Sorry, what was that question?
Know what kind of medications that we would most commonly see in a inhaler. For example, oxygen, epinephrine, albuterol. Which one is probably going to be in a metered dose? Albuterol. Know the common side effects of the medications you can administer as an EMR. So that's like epinephrine, albuterol. Side effects being for those two like rapid heart rates. Know the indications for glucose administration. So when would we give someone sugar? And also, anytime we're gonna give any medication by mouth, like glucose or aspirin, what do we have to make, anytime we're giving something by mouth, what do we have to make sure of? That we don't, that they're alert, oriented, that we're not worried about aspiration.
Hold on.
Hey, you're good.
What's the question?
I said, hold on a second, because I wasn't finished writing.
Okay, no,
But now you're good.
I'm kind of reading it, because a lot of this stuff I kind of already covered. So and I would say like the medications give at the EMR level. I can just say, kind of know why, when we give them, when we don't give them, what side effects are for all the medications that we went through. What type of patients we usually see using pursed lip breathing? That's the and a lot of times they're doing And please, I'm not judging. Not judging. I've been trying to quit chewing for 20 years. Obviously, I haven't won that battle.
Tomorrow's a new day.
No,
That's
it's not. Know what symptoms someone might complain of with an abdominal aortic aneurysm? Here's one. What's the difference between an artery and a vein?
Arteries carry blood away from the heart, and carry blood to the heart.
Bingo. Bingo. Majority of the arteries in your body carry oxygenated blood, majority of them, except for the pulmonary artery. But it's anything that's taking blood away from the heart is an artery. If it's returning blood to the heart, it's a vein. Silent MI, do you remember the demographics that are high risk?
For what?
A demographic that's a high risk for a silent heart attack, AKA MI. And it will, the question is, like MI. So MI stands for heart attack, myocardial infarction. And the people who usually get silent MIs don't have chest pain are your elderly, female, diabetics. Know what a good tool for guiding oxygen therapy is? I'll give you a clue, we clip it on a finger.
So can you say it one more time, please?
Yeah, what's a tool we can use to guide oxygen therapy? Did I talk to you guys about jugular vein distension? So, you know, you can get jugular vein distension. Basically, jugular vein distension indicates your heart's not emptying properly. So we're getting backup. And we can see it not only with collapsed lungs, fluid around the heart, but heart failure as well. Know your Cincinnati stroke scale? That's basically smile, arm strength, and speech. Know the importance of obtaining a last known well time in a possible stroke patient. And know your comic mimics of a stroke, like low blood sugars. Hypoglycemia is probably the most common.
I'm sorry, can you repeat that one?
Yeah, just, I know that low blood sugar, also known as hypoglycemia, is your largest mimic of a stroke. Know what happens in anaphylaxis? And what the adult dose of epinephrine is. What findings do we expect to see in severe hypothermia? know what's the biggest factor of a motor vehicle accident? We're kind of moving into trauma, but remember ABCs, unless we see life-threatening hemorrhage, then it's XABC. So treat life-threatening bleeds first. What's our next step if direct pressure isn't working for a bleed?
Wait, what?
The next step if direct pressure isn't working.
That's right.
So, yep, turn. And honestly now, if you've got a severe, you got blood spurting out of an arm or leg, you can just go right to tourniquet. But usually direct pressure is applied while someone's getting the tourniquet ready. Know what critical burns are? Critical burns, it's like elderly pediatrics. Burns to the hands, feet, face, greater than 50% body surface area, or circumferential, or burns that are completely encirculating an extremity.
Hold on.
Can you repeat that?
Yes, know what your critical burns are. Be able to differentiate the assessment of your different degree burns. It's like, what does a first degree or a superficial, partial thickness, and full thickness burn? How do they present? You know, for example, a full thickness burn is not painful because you've burnt all the nerve endings. One of the rule of palms for estimating body surface area, do we use our palm or the patient's palm?
Patience.
Patience.
And we're gonna move into some kind of musculoskeletal trauma and that we're gonna talk about tonight, but you're gonna see the term, there's a term crepitus. Has anyone ever heard of that?
Say it again, please.
Crepitus. So crepitus, which we'll talk about when I do the lecture tonight, like if I'm palpating an arm and I can feel this like kind of crunching, like if you took a chicken bone and broke it and then rubbed the ends,
Okay, let's.
that's what crepitus is. So crepitus is a pretty good indicator that you've got a bone fracture. We're gonna differentiate between what's a closed and what's an open fracture. And just some questions on general fracture management, which I will cover tonight.
Fracture management.
What's it?
I was just repeating what you said.
Findings of a basilar skull fracture. The order of securing a person to a longboard. gonna go over that kind of Saturday. I know we did some longboards, kind of one of our early classes, but now we're gonna throw in there a trauma patient. So when we secure someone to a longboard, someone should be maintaining manual cervical stabilization. So there's not traction, we're just holding their head still, trying to prevent it from moving. So when you're securing them to a board, we do the chest first, then down, and then we come back and do the head. And the reason we do that, because if we're in the middle of boarding them, and they start to, like they're gonna throw up, we gotta tip the board to the side, I can hold their head still and keep it in neutral alignment, versus if you secure their head, and then we roll them, the whole body's gonna, so then we're gonna manipulate the neck. So that's why we do chest, pelvis, then the head. Know what a tension pneumothorax is? Then you're gonna wanna know the 3 stages of labor. I'm not talking about going to work, I'm talking about pushing a baby out. Probably the best position to transport a female in her 3rd trimester, which Jesse will cover Saturday. Steps for continual uterine bleeding after childbirth, or vaginal bleeding.
Say that one more time, please.
Basically, what do we do if they, we deliver the baby, but we have continual vaginal bleeding? So how do we kind of stop that? What we do immediately upon delivery of a baby. Has everybody seen the hazmat placards where you got a red color, a blue color, a yellow color, and a white? Kind of know what red usually, and this is something that we cover next week, but, red is regarding flammable hazard, blue is health hazard, yellow is radioactive. So kind of know what those different colors represent. And then the last few questions are in regards to triage, which we're going to cover. So mass casualty incident triage, like what's a staging area? What do the different color tags represent? And to just give a little preview to that, it's, red is the most critical, green is the stable, black is deceased. We show up to a van, let's say, group of college kids on their way back from Hurley, rolls over on Highway 51, we got eight people involved in the accident. We gotta decide who's going to the hospital first, who aren't we wasting resources on, who do we treat, so on and so forth. And that's it. That'll be your final exam. So kind of the plan for the final exam will be on that last Saturday. We'll have a couple stations set up, so if you're not in a station, you can be taking your, working on your written exam. It's basically gonna be, you can go to a station, come back, and, in between stations, just be working on the final exam. You should be able to grade it right away while you're here.
You said they're multiple choice.
They're all multiple choice.
There's no, it was a joke as a written.
Nope, it's just, it'll look exactly like this.
So,
There's not a short answer question.
There's no short answer, you don't have to write an essay.
Thank
It's just A, B, C, D, A, B, C, D, and it's all one choice, none of them are choose the best answer. There's no all of the above,
There's no bubbles.
and their answers aren't all C.
Damn. Is it D?
Any questions on that? Okay, let's, we'll take a quick breather, I'll reset, and we'll get, kind of go over some musculoskeletal stuff. But one thing I said from day one is that some of these Wednesday nights, we try to get you out a little bit earlier. Tonight's gonna be that night. So we just, by the time I get done, we get lab station set up, we're just gonna focus on all that.
Will this be the time for my vacation story?
Yes, so as soon as we come back from break, Corey's gonna give us a good example of where you guys might be able to jump in without being.
Isn't some, I was gonna say, some of them are crazy.
Seriously?
They're kind of straightforward. On that one.
At the airport or? Okay, you're not flying, you're. Yeah. Not drinking enough or just
I have a whole big pillow.
drinking too much the day before? Okay.
Oh, yeah, you did. Oh, did you? Oh, yeah, you told me that. He's been getting up pretty early.
What are you doing here?
He's not still flying.
What did you see?
Thought you weren't going here anymore.
The map, where we just both of our work schedules, it's only open.
7 to 7.
I know, and we pay like, it's not by the end of this month, thank God, so I'll be so I can just do like bodies and like yoga. I don't really like weightlifting. I do it on Facebook,
Yep.
like
Yeah,
volleyball,
absolutely.
and I just, I'll do it sometimes, but I just don't like people looking at me. I don't like that.
You didn't know it or you weren't even doing
I didn't think I
or
was
you're
there. Just like this.
Yeah.
Okay.
You're there at 6 o'clock in the morning.
Well, my school kids are trying to shade.
Sir.
Yeah, he told me, he's like, "Oh, I saw that one." I literally could not. Because he came back from, like, 9, and I was still sleeping. She's like in my face, it's like,
That's good.
why? It's like, man, like,
This
they,
big, giant, fucking black wolf.
he's like,
Cause
oh.
all the other wolves will be like on the tree line, and then they'll be like sniffing around, whatever.
That's their call.
We'll just, out of nowhere, boom, I was just looking out in the front yard, or I was just out there, outside, he's standing there.
Usually he is too, he's thinking,
But he's giant, and he just looks at us. What was it, last summer, I think it was, I was out there.
Can we,
No, summer before.
can we, yeah, look at one.
Oh, I know it.
What you're having. For driving? Absolutely.
Like beavers?
For working in the housing authority. Looking for one.
I know, I.
Did he really?
Whatever.
Your payments didn't go down on anything, did they? Yeah. Well, they're gonna be looking for another employee then, part-time.
I think they went to go like coughing, and I went, whoops, no, it's training. And I went,
Over tomorrow.
There we go. Now we're going. So this is at, one of the training videos we use for wound packing, which everyone's gonna get to practice. It's not on a tape. So what they did here in the video is they do have a pig, and basically they put the pig under anesthesia, so they put a breathing tube in it, so it's not, they didn't do it, well, it's alive, but it's, not feeling it. So if any, animal rights people, I'm sorry, but this is how that we need to train. So what they do is they take the pig and they basically dissect down and they cut the femoral artery. And then they practice packing the wound.
We get to learn this next week.
Did the pig survive? I think they survived the wounds, but probably ended up being breakfast sausage a little later after they were done.
Amendable for tourniquet placement. The use of combat gauze is very similar to cotton gauze, so
Don't
following
worry
those
so much
principles
about
is
the-
easy and will ensure successful application.
So
First, examine the wound and identify the point of bleeding. Then, pack combat gauze directly over the source of bleeding and ensure you have good.
second page.
I didn't see
No, just returning station.
So you could see the wound was spurting a little bit, and immediately you're putting a finger with that wound directly on that source of bleeding, and then trying to pack while maintaining pressure on as much as you can.
Initial contact. Continue to pack the entire dressing while maintaining good contact.
It's a pretty
Use
massive
the
wound
entire
cavity.
dressing
You're
will
probably
ensure
not gonna be able to
proper
fill the
amount of
entire
agent will
wound
be delivered
cavity up.
into the wound.
How similar?
Lastly, apply 2 to 3 minutes of direct pressure.
What was the question?
How similar would like a pig be to a human? Like-
Almost identical.
Okay.
In fact, the pig is probably structurally the most close to human anatomy as you're gonna get. And what I mean is if we took a primate.
Yeah.
And I took its chest plate, opened its abdomen up and said, look at this, and we had a human body next to it, they look very different. But if you take a pig and you took the chest plate off structurally, anatomically, it's almost identical to that of a human. And so you'll see what here do is after we pack that wound, then it's direct pressure, and for a leg wound, literally one person's gonna be pretty much leaning on it. Try to hold pressure for 2 to 3 minutes, and you'll see them actually work the wound
This
afterwards.
period of direct pressure is important to ensure the hemostatic agent is properly effective in the wound. Periodically, check placement of the dressing and ensure it is still properly placed and there is no active bleeding from the edges. Do not lift the dressing to reassess. Ensure proper positioning and continue to hold pressure and let the active ingredient work. Occasionally, with difficult placements, the bandage will become completely soaked through and there will still be active bleeding. In these situations, you must entirely remove the old gauze and replace it with a completely new roll, using the same steps as previously mentioned. After 2 to 3 minutes of direct pressure, bandage the wound to secure the dressing in place. This can be done with any common field dressing or elastic bandage. Occasionally, a combat wound may have a large amount of pooled blood. In these cases, it is helpful to wipe away any pooled blood. Do this with your hand or a wad of cotton gauze. This helps to identify the wound and ensure direct contact with the point of bleeding. This is the only additional step required. All other steps are the same as a typical application.
Now that is an extreme example that you guys won't be wiping wound. It's more tactical combat care. If in the event you need a pack wound, it's literally just try to get that directly on the source. And if I have time, we're gonna do it Saturday. If you have a wound packing model that we'll have you guys all practice packing the wound on and applying the tourniquet. Any questions on that?
Yeah, where they said if it soaks through or if there's bleeding around the edge to remove it and start over again?
No,
You're not
what
just
we're gonna
adding
do
on
is
top?
never, once you start applying pressure, never take that out. We try to, pack some more in along the edges of it.
But they didn't say if it's 100% soap. I feel like what Tyler said, that's what I heard too. He said to remove it and
Yeah.
With current practice, and again, this is for tactical
okay,
care, it's a little bit different in that situation.
okay.
But for you guys, for 911 EMS, once you initiate packing, leave it in place. With that, and Corey, I jumped in front of you. Want to share your quick EMR story?
Yeah, that's what the video said.
So this is one of those stories that is in the chapter, but can only happen to Corey and me. So we just got back from Puerto Rico. On the flight down, we went from O'Hare to Puerto Rico, and halfway down, I don't know, let's say it's over the Bahamas, flight attendant gets on and says, "Is there a doctor on board? We've got a medical emergency." Maybe and I look at each other like, so I stand up, and behind me 4 or 5 rows, there's people standing around, and there's a girl on her back, in the middle of the aisle. You know how tight planes are, there's no room, so maybe and I would get up and walk back there. There was another girl that came to her head, happened to be a nurse, so there's no room. I straddle her, Mamie gets to her side, there's a nurse at her head. I lean down to check her pulse. She's kind of conscious, very weak pulse, but I immediately took and tell her skin. It was warm, it was sweaty. I could lean it forward, and I asked her if she had difficulty breathing. She was able to tell me she did. By this time, there's 2 flight attendants behind me. There's a flight attendant behind with a nurse, and we're in this tube. So the flight attendant was given a big med bag from the airplane. It had meds, it had tools, it was really, really, really cool. She started to take blood pressure. Mamie's doing the verbal assessment. I asked for a blood glucose monitor, and took the first initial glucose. Her blood pressure, her systolic was, I can't remember because I didn't take it, but it was 90 over something. So it was pretty low. So when I first tried to check it by the wrist, it was hard to find. I didn't immediately find it. Took her blood glucose. She's starting to come around a little bit. Took her blood glucose. The first one was at 62. What does that tell you? Low blood glucose. What was her skin?
Sweaty.
Sweaty. Definitely sweaty. Definitely hot to the touch. We were going to Puerto Rico, so there were a lot of dark-skinned people on there, so I couldn't tell she was flushed because she's on the floor. That would be another sign as well. The nurse at the head found the oral glucose in the med bag, and this is not how you would administer an oral glucose. It's just like, have they seen them yet? You've seen the tubes of oral glucose, right? So it looked exactly like we've seen. The girl's laying flat on her back, and the nurse takes it straight in the middle and just squirts it in her mouth. So Mamie grabs her head, turns it to the side, and she did have a gag reflex. She was becoming alert at this point, but it's tight. I've got 2 flight attendants behind me, asking me what's going on because they need to give the pilot information. So I'm giving them the play-by-play. They've got an AED over my left shoulder. They were able to give me oxygen. I mean, the oxygen tank was not even this big. It was a tiny little tank, and it wasn't the mask that we looked at. It was the mask that come out of the ceiling. So Mamie puts that on her. To my right, there were 3 seats, and it was a mom, 2 little kids, 2 little girls. And they're in the front row seat of this action. So the whole time I'm doing my thing, smiling at them, talking to them, talking them through it, because otherwise they could be like traumatized. And I'm using their seat as the toolbox, for all the glucometer stuff. So then I took her blood glucose the second time. It came up into the 70s. And then the flight attendant behind me asked the $1 million question. Our flight is 3 hours late at this time. We had to de-ice in O'Hare, and everybody's ready to get to Puerto Rico. $1 million question. Should we land the plane? And I can just feel everybody in the plane like,
Telling you, man.
don't do it! So we didn't land the plane. So then we had a second oral glucose, gave that to her. The third glucometer check was in the 90s, stood her up. She was feeling much better. The flight attendants gave her oxygen.
Orange juice?
Orange juice, I'm sorry. Orange juice. We already gave her oxygen. Flight attendants gave her orange juice, and Mamie checked on her a couple times in the flight, and on our merry way we went. So it can happen anywhere, anywhere. And everybody works down that same patient assessment sheet. You know, we had never met this nurse before at the head, but the tools we were given were all the tools you've seen. The patient assessment sheet was the same assessment sheet that she's had. So even though we never met her, we were all able to instantly just work together based on what you're learning in this class. So yeah, it was crazy. It was fun.
Good job.
It only happened to Corey and me.
Well, and to keep your cool. You know,
Yeah,
that's the
yeah,
key.
over the Bahamas.
Yeah.
Yeah.
I would come with the kids a little more.
Oh, cool. I was able to help you to see that.
So if she's on her back, you know,
Kids wanna
pick
see
her
what
up
record
sideways,
registration-
let her,
Anything,
but
simultaneous, oral,
don't
and
grab
rectal.
it right there.
So, you observe a lot, that's why like natural under your tongue, the oral is like.
Jason did CPR.
Jason, we'll get outside.
Rub it, they're gone.
Yeah, I think,
So, to observe.
everyone might wanna take a second, just,
Look outside.
even if you gotta get up, look out the window, the way that mist or fog is rolling in off the lake.
So that's where Vanessa lives, right across the street. That's her view every night.
And I think we're having, after one of the classes, party at Vanessa's, right?
Absolutely.
Yeah, the last Saturday, because
We
she
can
won't
have
be
her.
here.
Yeah! I think I've got her house keys.
Cook out at your place?
There you go.
Yeah, always take, get a chance to look at that, at least not to be
It
morbid,
never
but
gets old.
I never know if that's gonna be my last one.
Yeah. Beautiful.
She has no idea.
So with that, let's talk about some bone breaks. So kind of musculoskeletal trauma, this is gonna be, of the trauma issues you deal with as an EMR, probably one of the more common. Everything from, sprains, strains, fractures, dislocations. The good news is regardless, we treat them all the same. So let's just kind of jump into it. We'll hit on the big points. So a fracture is when there's been compromise to the integrity of the bone. So anything from a partial fracture where it's cracked but not separated, to where it can actually disrupt the skin. So the difference between an open fracture and a closed fracture, open fractures are where the bone has perforated the skin. Now, more often than not, when you see open fractures, what we find on our initial assessment is a laceration. A laceration or an avulsion of some type, but we see a large soft tissue injury. That often what happens in trauma is the force of trauma, the bone breaks through the skin, and then the muscle retracts the bone back in. So when we arrive, it just looks like a big cut. Control bleeding if needed. I will tell you that of the majority of open fractures I see, bleeding is actually moderate to minimal. That very seldom have I been to an open fracture where there is bleeding. And if it is an arm or a leg, and we see a hole and blood spurting out, put a tourniquet. Okay? So, obviously, what do signs and symptoms? And I'm just gonna throw in here, when we talk fractures, and we'll break apart the difference between sprain, strain, dislocation, and fractures in a little bit, but they're all gonna really present kind of the same. Meaning, they're probably gonna have pain and tenderness. Probably the biggest complaint when we get to to suspected fractures or dislocations is pain. Pain on tenderness, obviously we touch it. So when we're doing assessment, you guys remember like doing a head to toe where we're kind of pushing on the leg and on the arms as we go on. That's trying to palpate to elicit tenderness. But if we show up in an arm, as we'll see some photos of some angulated extremities, you don't need to necessarily palpate it. You know, we can see it doesn't look the way it should. Deformity, meaning it's not the shape it should be, discolor, paresthesia, anesthesia. It can actually, some fractures can be painless, especially if there's been nervous disruption. They can't move it. And if there's been vascular damage from the site, we may lose distal pulses, or even a delayed capillary refill distal to the injury. There's just that's a good X-ray. Actually looks like a pediatric, I think, but that's kind of what we call a Colles fracture, relatively common. So there's the X-ray. There's a hand. So you kind of see arm shouldn't be shaped like that, right?
In the case of an open fracture, you do have bleeding that you need to control, so you apply direct pressure, that's gonna be insanely painful. The patient's not gonna tolerate that well, but.
Yeah, you're gonna have to put some pressure on it, but you gotta remember, so let's look at this up a little bit. Let's say our opening is here, right? Even down here and kind of where that bends. If we're open there and we, you know, if you're exsanguinating, the blood loss will kill them,
Right.
the fracture. So if they're exsanguinating, honestly, if I saw that exsanguinating, you know, bleeding severely, I'd go above with a tourniquet. So we don't expect you to know the different types of fractures, but kind of what this is getting here, just showing the different types. So the comminuted, that's where we've actually got two sections of bone separated. Impacted fractures, if you can imagine, I jump off a second-story roof and I land on a driveway, that it's more of an indirect fracture where, you know, I'll probably fracture my heels, but I'll also fracture my trauma from that force being moved up my bones. Green stick fractures, kind of a little splintering. This is kind of the common in pediatrics. The littles, the bones aren't completely strengthened yet, so almost like if you took a toothpick and just bent it a little bit, where you get that little bit of splintering, maybe halfway through. A hairline. Again, just the different types, and it's not very important for you to, we're not asking you to, in fact, even I don't differentiate. We just, if it's painful, swollen, we're just going to splint it and they'll x-ray. So what are the bad things that happen with fractures besides bone actually being disrupted? Obviously, bleeding can be a concern. So remember that in your bones, that's where blood is produced. So you've got blood that's coming out from actually the bone itself. If the fracture happens to sever an artery or a large vein, you can have external bleeding. Obviously, infection's a concern. So, you know, we're not going to be debriding open wounds in the field. You know, what we do in the field is we do our best to keep it as sterile as we can, but I think we've used a case study before. We had a car rollover, pretty devastating leg injury. And then this person was kind of half thrown out of the vehicle, so you got mud, grass, debris all in the wound. We're not cleaning it and debriding it in the field. We're wrapping it up to prevent blood loss and getting to the hospital. But infection's very much a concern downrange. So sprains and strains. If you sprain your ankle, have like ligament damage, or you strain a muscle, it can be swollen, painful, without deformity. But then again, so can fractures. So again, we're really not trying to differentiate. If a bone or a joint injury, swollen, painful, we just treat it like it's a fracture dislocation, splint it, and get them to the hospital. Not necessarily all injuries need to go by ambulance, so it could be very common for you guys to show up to a dislocated knee or, you know, an ankle fracture, and we splint it, and then they go by private vehicle to the hospital. That's reasonable. I'm sure at Windman especially, we can even have a collarbone fracture and we sling it, and they ask, and my husband or wife drive me to the hospital, and I'm sure, you know, it's a very reasonable thing. I don't want to jump too far ahead. Dislocations are joints. Most commonly, I think probably the knee or elbow dislocation. I probably see 10 knee dislocations to every one elbow. In fact, I can probably count to one hand how many elbow dislocations I've seen. But knee dislocations are relatively common. And I think before the end of my career, it's coming very close where I think you'll see even in EMS that we're putting kneecaps back in place in the field. But we won't be covering that tonight.
I've done that to myself.
Yeah. The big issue is that they still need to be evaluated, because by placing like the knee back in place is that there can be some ligament damage from the actual injury, so you should probably still get evaluated. So there's that actually looks more like a distal femur knee dislocation. Usually knee dislocations don't look that gruesome.
Right here, Jason.
That's what a knee dislocation looks like.
Yeah.
So if you can imagine the kneecap comes up and out of that groove, and we usually rotate to one of the sides. It looks nastier than what it is.
It didn't hurt.
It hurts?
Oh, it didn't hurt much.
No? How about when they put it back in?
No, not either.
Or they give you a Versat first?
No. They didn't give me nothing. It just straightened my knee out, and boom, I went back home.
So you just kind of grab it, pull it in. I talked about that. Femur and pelvis. So these are probably two of the more concerning type of fractures. So we're going to talk briefly about traction splinting, a mid-shaft femur fracture. But that's not, the EMR level won't be tested out on that. But when you guys take EMT, we spend a lot of time with traction splinting. The pelvis, I think what's most concerning, first off, your pelvic girdle, here in the front, in fact, if you're, I don't want to sound gross, but as you feel down kind of almost right above suprapubic region, you'll feel a bone that goes across here. That's called your pubis symphysis bone. And that's kind of what holds your pelvis together. And there's a little chunk of cartilage. And if the force is significant enough, you can actually separate that pubis symphysis bone, and that pelvis will actually do what's called an open book fracture, lay out like this. The pelvis, because it's such a strong, rigid bone, that if the force of trauma is enough to fracture the pelvic bone, we're very worried about concurrent organ trauma. That's a pretty significant force it takes to fracture a pelvis. The pelvis and the femur can also bleed a lot internally. So one fracture in a pelvis can bleed about half a liter of blood. Your femur can bleed up to about 1.5 liters of blood. So in the average traumatic pelvic fracture, there's about 7 fractures associated with that injury. So do the math. You can be looking at 2 to 3 liters of blood loss just from a pelvic fracture. So, and remember, I said pelvic fractures are different than hip dislocations. Pelvic fracture is very difficult to assess. I've seen more pelvic fractures that I didn't know it was a pelvic fracture until we got the report in the hospital. Meaning, we grabbed their pelvis, kind of did that pelvic assessment, might elicit a little discomfort or pain, then I find out a day later that they had a shattered pelvis. So it's, the only times I've ever seen an open book pelvic fracture is when I've been a coroner. They're deceased. So I've never really seen an open book on a person to be alive.
What kind of injuries would cause that?
Hmm?
What kind of injuries would cause?
Falls from significant height, severe motor vehicle, or ejections from cars, motorcycles, any type of UTV, off-road type. It's a very significant rapid deceleration, blunt trauma that would cause. Mrs. Smith that just slips on the floor and falls, probably not enough force from the same level fall that caused. And we'll kind of, just because it's relatively common, I'm going to just venture away from the slides a little bit. Let's talk about hip fractures. This is a very common call that we get in EMS. So it's usually associated with a fall. Has anyone ever heard of osteoporosis? So a lot of degenerative bone diseases, which are very common, more common in the female population. It doesn't take, it can just be the stress of walking can cause a fracture or dislocation. The bones can become brittle. If you have a proximal femur fracture that's up close to the hip joint, it's almost impossible to be able to differentiate that from a hip dislocation. They'll present the same. But the hip, it's a ball and socket joint, so that hip can pop out. And what's classic presentation is the person's on the floor. When that hip pops out, the muscle's going to retract that hip, so it's going to shorten the leg, and it will either rotate inward or outward. So if the hip pops out the back, it shortens and rotates in. If it pops out the front, it shortens and rotates out. Not important for you to differentiate anterior from posterior. Just a shorten, they're sitting there and you look at their feet, and one's about that much shorter and it's rotated in or out. That's pretty diagnostic of a hip dislocation. What do we do for them? Handle them gently. There's not much with the EMR. You pretty much just sit with them, do a full body assessment to see if they hit their head or any other injuries, but pretty much wait till the ambulance gets there. And we try to do our best to make them comfortable. We can use a scoop to pick them up to limit manipulation of the hip because they're painful. Usually with ALS, we're just going to hit them with pain medicine before we move them. So pain is probably the biggest patient care issue that we deal with, and then we just transport them, and they usually require surgical repair. So we're not going to fix a hip dislocation in the field. That one's almost an open fracture. One of the most important things we do with suspected musculoskeletal injury is that we need to check what's called CMS before and after we splint. So CMS stands for circulation, movement, sensation. So we're trying to assess if there's been any nerve or vascular damage from the fracture or injury. So we do that if it's a leg or an arm. I'm going to do a cap refill test. Or on the toes to see do we have blood flow, even feel for a pulse. So arm injury, I'll feel for a radial pulse. Leg injury, I'll feel for a dorsalis pedis pulse, it's called, which can be hard to find, but going up kind of between your, I guess if this is my big toe, which the hand isn't the best example, but I'm going to, between my big toe and my next toe, I'm sliding my fingers up and just adding light pressure to the foot. It's something you guys can practice tonight, trying to find your pulse on your foot. But it can be hard to find, even on someone who has a pulse. If you do find a pulse when you're doing an assessment, it's real good to just take a pen, make an X where the pulse was, so that as we're doing reassessments, we know right where it was. But cap refill, or even just pushing down on the skin, if it pinkens back up after we blanch it, that tells us that it's blood.
What does the S stand for?
What's that?
What's the S stand for?
So circulation, checking for blood flow, movement, and I'm not going to ask someone with a broken arm or leg, hey, move your arm for me. But I might say, can you wiggle your fingers or toes? And that tells me that I've got nervous function past that injury. And then sensation is I might just grab their finger and say, can you feel me touching your finger? Can you feel me touching your toe? So I'm checking circulation, movement, sensation, past or distal to the injury. And we want to check that right away. And then if we splint it, we want to check it when we're done. That's an open fracture. I know it looks kind of gruesome, but the bone actually almost disconnected from the ankle. So
That's an ankle?
that's a very, that can be surgically repaired. So it looks more gruesome than what it is. I mean, you get this one could go to Howard Young and the surgeon there can fix it. This doesn't need to go to a trauma. If that's the only thing.
Too big.
Good counsel, don't they?
If you ever want to see something nasty, watch YouTube video of orthopedic surgery.
You ever watch a show called Scarred in like the early 2000s? Yeah, they basically just showed you injuries and how they did them. Like people doing like tricks.
Oh, yeah.
BMX,
So like Jackass?
I can't watch shows like that.
It's all, it was like.
I can't watch the guy does the kickboxing
Yeah.
anymore, ever since that one where he kicked them.
Oh, Anderson Silva?
Oh my god.
Okay, so universal care for anything we suspect is dislocated or injured. Pretty straightforward. Control external bleeding. Always consider inline stabilization if we're concerned about a potential neck injury. So just keeping their head still. Oxygen if needed. Splint injuries and cold packs and elevation. So we'll kind of look at the different types of splints. I'm just going to get to the basics of splinting here. So a lot of the reason we're splinting is to prevent it's not fixing it, it's just preventing it from additional damage. So we're just trying to keep the arm or leg or whatever's broke still. Obviously, number one, we have to expose the injury. We have to see what we're working at. This is where people get mad, and if they're awake, we'll talk to them, hey, we got to cut some clothes off. Most people are good. What's tough is when you got the motorcycle guy who's got the leathers, and they spent a lot of money on them. We got two options. We can cut it, which is going to be easier, or we can remove it, which is going to be excruciatingly painful. And most bikers will choose the pain over cutting their leathers. But critical unresponsive patients, even the snowmobile gear now is, I don't know, what do you guys, who here snowmobiles? Corey, what do you spend on your outfit?
Dave and Sarah and I just suited him up without a helmet at $1,300.
Yeah.
Without a helmet.
But we cut.
Yep.
I didn't get a choice.
So
A lot of times, if you're pretty critical, I don't even ask, I just get to cut. If I'm cutting without asking, then you just need to focus on your next breath. So, control hemorrhage. So, splinting, the basic rule of thumb, and there are 1,000 different ways to splint things. If we suspect a bone, we want to splint from the joint above it to the joint below it. If we suspect a joint, we splint the bone below it to the bone above it. So elbow, we're immobilizing this bone to this bone. For a joint, if it's the bone, I'm immobilizing this joint to this joint. So we're pretty much trying to keep that area from moving. I think that's kind of, when you're showing up as an EMR, 9 times out of 10, you guys will not be splinting at all. Your job is to hold it still, get an assessment, control bleeding if you have to, because when the ambulance shows up, the ambulance is it's best if we can look at the injury as well. So the need for you guys to carry splinting material in your kits, very, very low. But we're still going to have to kind of cover the basics of it. So what this is showing what's essentially a rigid splint, we call. And we carry rigid splints, I think we do, on ambulances, or boarded splints.
We have some antiques.
Yeah, I'm a board splint guy. So a rigid splint is, think of like a stick or a piece of wood, something that we can't bend and we can't move. And then we line them up on each side and then splint it. So if my arm is bent, let's say like this, I would run one splint on this side and one splint on this side rather than top and bottom, right? So we're basically just immobilizing that injury in the position we found. Air splints and vacuum splints, we do have vacuum splints that we'll play with too. So air splints are almost like a inflatable pillow that you slide over and we put air in. Kind of. Vacuum splints are like all the little beads, I think is what it would call. So you basically put this like blanket around and then you hook up a vacuum and you suck all the air out. And a rigid splint, like we can use a rigid, we actually have a backboard besides it. So you can roll something onto it, suck the air out, and like you can't bend or trying to think what the main splints that we'll use, what do we call them, the blue,
Pro splints?
the pro splints, which are kind of classified as a rigid splint, I guess, but it's almost like a foam with Velcro, but you can still move it. And again, this is all stuff we're gonna play with on Saturday.
Cool.
But it's just a vacuum splint, wrap it on, suck the air out.
Sam splint?
Sand splints, we have those are bendable.
Is that a bed sheet?
They're good for like wrist stuff.
Or is that a blanket?
Soft splints, these are what I use a lot, especially for ankles. Pillow, roll up something soft, I'll roll up, basically enclose the entire extremity, and then we use cravats to basically just tie it together. So if you wanted to, with this splint, I could pick my leg up and it could still move a little bit, but where most people are gonna protect that extremity from moving, they don't want to move it.
Oh, there's a towel.
Just showing the vacuum splint.
Do they have a foam splint in there?
What's it?
Do they have a foam splint as an example?
Yeah, I guess the foam splint would be kind of what the pro splints would be. So what this is a traction splint. And this might be something that you would have to assist with. So we use traction splinting when we suspect isolated midshaft femur fractures. In my 26 years, I think I've seen traction splints used more since I've been up here than I did in my 26 years at Wisconsin Rapids.
Is that good?
It's weird. So
It's old school, we're old school.
I guess first let me explain what a traction splint. So the femur is a pretty strong bone surrounded by pretty strong muscles in the legs, right? So when I snap a femur, the muscle is actually going to pull the bone like this. Okay, so it's going to shorten the leg, right? Was like this, femur breaks, muscle constricted. So we got bone edge on bone edge. And what we do with traction splints is you literally pull traction. So we pull the leg out and then we splint it in place like this.
Does that decrease pain?
What's it?
Does that decrease the pain?
Of the times that I've seen it used, yeah. A lot of the pain is from that muscle contraction and the bone kind of digging into the bone. So by pulling it apart, you're kind of relieving some of that pain. And
Would there be any bleeding because you're doing that at all? Or
not if it's closed. so it can bleed internally. It's gonna swell. So what we do is you literally grab a leg and you pull back and lean. And this may be something where the ambulance asks for an EMR to help with, and we will practice some kind of traction maneuvers on Saturday, but you're basically just grabbing them by the ankle and one foot kind of right just below the calf and leaning back. The problem is if you're in that position, it can take sometimes 3 to 4 minutes to get the traction splint on. So if you're the one holding traction, you have to continue to hold that traction. When can't we use a traction splint? If there's any other injury on that extremity besides the femur. So if I have a femur fracture and I have a tib-fib fracture, that's, now I'm pulling on two different, you're just not gonna, you're gonna, we'll start to rip muscle before we can get traction. If we suspect a hip dislocation, we're not gonna be able to get good, it's not gonna be able to provide traction. So I think the reason we haven't used it is the times that I've seen femur fractures, there's been contraindications. So it's femur, hip, tib-fib, multi-system trauma. That we haven't had that isolated mid-shaft femur fracture. I think we see isolated mid-shaft femur fractures from direct injury, from like bicycle, e-bikes, the type of stuff we see here that we don't see in Wisconsin Rapids. It's very seldom to see people on a bike doing exercise where I came from.
But also because of our long transport times too, like if you got a 45-minute transport time, you'd want to put that traction on there for comfort, where in rapids, if you have shorter transport times.
No, it's because every femur fracture I've seen, it's been like there's contraindications. That there's lower extremity fractures in addition to the femur. It's usually high mechanism trauma. So those patients, actually the fractures are the least of our worries. We've put them on a board and strapped their legs onto the board. We're worried about belly, chest, back, much more trauma. So very seldom did we see that mid-shaft. Isolated. That's the only thing that's broken. Does that make sense? So we can only apply traction if that's the only injury site on that extremity.
They're gonna be in a lot of pain when you do that.
Yeah, we're hitting them with pain medicine pretty quick.
You do that before you pull.
But I've also seen I've seen femur fractures where they're uncomfortable, but they're not screaming. I've also seen very minor fractures where they're screaming. So, I mean, everyone's pain tolerance is a little bit different, but your adrenaline release on a fracture helps mask some of that pain, which is why we have to do those assessments. And I hate to go back to that example, but remember that I told you that car accident we had very devastating leg injury. His only complaint was back pain. Like I asked him, how's your leg? He said, oh, the legs are not that bad. My back. He just got screaming about his back. So the back is an example of a distracting injury. That was, and actually his back at the time was more my concern than was his leg. Because even though it looked devastating, it wasn't bleeding, it wasn't immediately threatening to his life, but internal organs, has he got a collapsed lung, things like that are much more concerning than that devastating leg injury. So I think we wrapped it, threw a splint on it, or a splint or something quick, I don't know, Corey, you
You didn't put a tourniquet on it though?
didn't need to. Although it really wasn't bleeding. Even though despite you could see bone, muscle, fat, everything was pretty well exposed, but it wasn't bleeding.
Did you find out what was wrong with his back?
What's it?
Did you find out what was wrong with his back? Like later on?
Nothing. Nothing, his back was fine. Which I thought he had broken. There's a lot of different types of traction splints. Now, sling and a swath, this is, we'll practice on this. In fact, anyone know why the Boy Scouts wear a handkerchief?
For that?
Because the handkerchief is a triangular bandage. It can be turned into a sling. And it's just, We actually, we cheat a little bit on the ambulance, and we have the commercial splints that we'll use, but we use a sling a lot, and this is kind of the bread and butter of what we do. So any arm injury, you sling it and swap it, it just prevents movement. So the sling will prevent up-down motion of the arm, and a swath, or what's called a binder, is where we run another one to prevent this kind of movement. Any injury to any part of the arm, we could put a rigid splint and then use this, sling and a swath with it. Clavicle injuries, which, not so much a dislocated shoulder, but when you break your collarbone. So everyone can feel your collarbone. It's not a very rigid bone, and not a lot of protection. It's very common to fracture that. When you fracture that bone, they'll present, probably seen them at Wingman before. There's some kind of splinting techniques that we can do, but most patients just prefer a sling and a swath, kind of immobilize it. Otherwise, we can do some splinting where you actually pull the shoulders back. So we take a triangular bandage and you just roll it into a single roll, and we do a circle around this shoulder and a circle around this shoulder, and then another one in back. You tie it together, and that will actually bring the shoulders back. So we can try that sometimes to see if that relieves pain. But a lot of times just splinting and mobilizing, ice is always good. Cold packs on an acute injury. When you apply cold packs, cold makes the blood vessels constrict a little bit, so it slows any bleeding down. And that's just showing swath. You'll see too, in the safety pin comes with this. When we put a sling on, there's always going to be a little bit of slack, so you just kind of pull it up and you put a safety pin pretty high. And again, just all different types of, we're going to play around with all this stuff. This is an A-frame splint. I use this a lot for knees. A-frame meaning here's her arm and it bends here. See how you're kind of making that letter A? So what that does, we put a board on each side and then we tie the boards together and then immobilize it on a sling, and that's going to prevent your arm from doing this. So this is, A-frame is very common with an elbow or a knee. Or depending on the patient, sometimes you just put a pro splint on and sling it and go to the hospital. That's the SAM splint. So the SAM splint, you can bend it and shape it. But because you can bend it, it's not completely stable, rigid splint either. That's the stuff I like, just wrapping a pillow around it. And I think with that, what time is it?
7:50.
It's what?
10 to 8.
10 to 8. All right, I do want to, I talked about chest trauma with you guys too, right? Collapsed lungs and what do you do if someone's got a hole in the chest? Well, I'll do that. So, I didn't show you guys a picture of the, so, there's a hole. This is just showing an example of occlusive dressing. This is a commercial one that's got a one-way valve impregnated on it. But otherwise, if you don't have that, just using a piece of plastic. And current recommendation, just tape it on all 4 sides. But just a piece of plastic right over the top. Now, this one, we're just going to look at a couple photos. And I will warn you, these are facial injuries and graphic. But we'll kind of look at worst case scenario and how we manage it.
Oh no.
So, this looks, here's the thing with facial injuries, I'm gonna tell you right now, they look worse than what they actually are. Facial injuries bleed a lot, they look devastating, but overall concern with facial injuries is bleeding control and airway. So a lot of times if someone's losing their airway, we work through this trauma to just suction, position, manage airway as best we can. So this is essentially avulsions to the eye. You can see the eyeball, the actual globe is intact and stable. What do we do for this? It's light dressing, and we just cover both eyes and transport. That it looks worse than what it actually is. This is an actual globe fracture where the globe of the eye has been injured again. Nothing we can do about that. Cover it and transport. This is an orbital fracture, which can happen on severe facial injuries where the bones of the skull, there's 4 muscles that hold your eye in, and then there's the optic nerve that kind of, there's some play in it. So you got 2 muscles, one at top, one bottom, one right, one left. If those muscles get disrupted, that's really the only thing holding your eyeball in. So extreme orbital fractures can rupture that muscle and the eyeball can protrude. Moist saline, we cover it, don't push it back.
Ow.
Impaled objects, now this is just a training, this isn't actual. Impaled objects anywhere in someone, we, for the most part, leave them in. So it's chest, arm. We just do what's shown here, is you start to bulk up around it to stabilize it, to keep it from moving. And then you start to get creative and wrapping it up. That is a Dixie cup. And that's one of the reasons we carry cups in the ambulance.
Cups.
After all of your years as a paramedic, is there one, like a couple things that still gross you out to this day? Because that's one of mine.
Something that grosses me out, the grossest thing I've ever seen in my entire career is my lieutenant coming out of the shower naked on a fire.
Okay. I meant like injuries.
No, I think it just, I don't know, probably paper
These are all
cuts between the
things I've
fingers.
seen.
Oh,
That
ow.
was the worst.
Or between the toes.
Yeah, or, yeah, no.
What are you doing to get this?
I don't know, the Jackass guys did it, and it's haunted me ever since.
So, and here, I mean, you can see, I mean, this person's alive, it's a pretty devastating injury. And this wound has been cleaned already, but this is just gonna be direct pressure. And my overall concern is, number one, can the person talk? So if they're talking and we don't hear gurgling, gurgling would indicate airway is compromised, that there's now blood in the airway. So this is just in the soft tissues, very close call to some greater vessels. But this would be direct pressure to potentially wound packing if it was actively bleeding. This is very, very severe, devastating. You can tell the fact that this person has a breathing tube in. There's concern about airway, but this appears to be almost a machete or hatchet type wound to the face. Again, as devastating as it is, it's going to be suctioning the airway. And what do we do, you know, as an EMR? We show up, persons like this unconscious gurgling. You're probably going to have to roll them on their side to allow drainage of blood out of their airway. And suction as best we can. Suction, bagging, or oxygen, suction. And we're just going back and forth between keeping that airway clear and administering oxygen. And then still kind of a rapid head-to-toe assessment to see if there's anything else. That don't get just focused on this. You know, if we can gurgle or if we can suction, position them to clear that airway, then we need a quick look at the neck, chest, belly. Are there other injuries that we might be missing? Another very kind of, and again, soft tissue injury, but this person very well could be talking to you, position, suction, clear his airway, and it's going to be some bleeding control. That looks like a dog bite. Again, looks devastating, but we're 5x9. We're putting some just pressure on it, or even giving it to the person. And, you know, for example, this person who's awake talking, or I shouldn't say awake, the fact that he doesn't have a breathing tube in tells me that he's relatively stable, but give him the dressing here, hold this to your face, I need to check the rest of you to see what's hurt. So it's bleeding control. This one's a little bit more concerning because he's elderly, so why would elderly concern me?
Internal.
False teeth. False teeth.
Yeah, teeth, airway compromise. What are, as we get older, what's a good likelihood that they might be taking over or take prescribed? Blood thinners. So blood thinners, it's going to be much more difficult to control the bleeding. But if they've got dentures or false teeth and they're loose, you take them off. Try to, if we can, keep them. Mostly because once they get repaired, they spend a lot of money on that stuff, so they'll want them back. I think that's just a nose injury. That's what my nose looked like when I fell flat on my face. Ear injuries. Sometimes that's just give someone a light dressing. And stab wound to the neck. Again, my concern here is exsanguination to, it's obviously not severely bleeding at this point. They've cleaned the wound, they stopped bleeding, but what's my big concern with this? Airway. Is the airway compromised? I think that, I guess, that might be, that's about it. I just wanted to kind of show some of that trauma, so.
That's great.
Again, the plan is Saturday, will be, probably about an hour and a half, and then it's just gonna be hands-on practice with bleeding control, splinting, kind of some longboarding with suspected cervical spine injuries. That's about it. So, any questions on that stuff, guys?
Do you think we'll go until 4 on Saturday?
I mean, yes, of course, that's the schedule.
Obviously.
Any other questions? Saturday's supposed to be nice, so it's gonna be tough. But that's why I wanted to get this done before May. Which we will be. Okay, so don't sweat it. I wanted to go over the final now, so we got like almost a month to kind of read up on some stuff, make your cheat card, whatever you gotta do.
Cheese card?
Well, your
Cheat card.
oh,
My hearing is terrible today.
I heard cheese.
well, you guys
I heard cheese card.
are free to go.
Okay.
Thank you.